This is the Stroke Committee for GETAC, and I want to call the roll here quickly. Fillingham here. Monica Haig, Cindy Hoff, Dick Huey, Ronnie Eichler, Deb Motz,
here.
Warren Porter, here. Paulina Sergott, Timothy Smith, and Denise Williams. Okay. Well, thank you guys for coming. First off, I would like to thank two members of our committee who this is their last meeting today. It's very nice for people to serve on this committee, as you know. The pay is scant and the hours are long. But Cindy Hoff is rotating off the committee this time, and she's not here, but thank her very much, and we'll send this certificate to her. And next is Dick Huey, and I want to thank you very much for serving and helping us out. We'll have two new members coming in on the next meeting, and we'll introduce everybody then. Next up is review of the current DSH EMS trauma system rules. As you guys know, we submitted rules last time. Are there any rules or additional things people want to talk about at this time? Hearing none, I'd like to go on to STRAC has a presentation that they want to give us. They have an amazing record of giving TPA, and it's very unique. And so we're going to hear how they do it, and maybe it'll help us do it as well.
Okay, good afternoon. My name is Justin Pruitt, and this is Dr. Emily Kidd. And we just wanted to share with everybody some of the things that we've been doing in STRAC. Just want to take a minute just to recognize the STRAC Stroke Committee. And without the individual stroke coordinators, none of this would have been even possible. So the driving force are all of the nurses there that you know, kind of put in the extra efforts. Just a little overview of STRAC, Southwest Texas Regional Advisory Council. Excuse me. We have 22 counties, 53 hospitals. 11 of those are primary stroke centers. 3 of those hospitals are seeking comprehensive status whenever that comes around. We have 71 EMS agencies. We also have in place through our criteria, our stroke alert criteria, where EMS units will bypass hospitals to go to a primary stroke center. So that's one of the things that is pretty cool about our region. We also have one other hospital who is seeking primary status. So we've got quite a few stroke centers in our area. So this is our stroke alert criteria. We have the Cincinnati Stroke Scale, and then we also talk about the time window within 8 hours, and I'll explain that here in just a second, and then the blood sugar component. So the paramedics will assess the patient on the Cincinnati Stroke Scale, and so if they find one or more of those, that includes them into the criteria, as long as if their last known well time is less than 8 hours and the blood sugar is between 60 and 600. The reason why we have less than 8 hours is because we also want to capture those patients who are outside the TPA window as possibly getting an intervention. So we are considering maybe changing that just to 4.5 hours, but we don't have a whole lot of data that supports that right now. We are looking at that for the future. And you'll see on some of these slides that some of the preliminary data we have will also kind of support this as well, the reason why we're thinking about the change. Okay, so this is how we define our activations. So we actually have two definitions. We look at whether the medics activated based on criteria and the actual disease itself. And so if we look over at the criteria, we have true activations. So that means that the stroke alert criteria was present and the medic actually called the stroke alert. And then a false activation is that the criteria is not present, but they went ahead and called the stroke alert. Usually what happens there is the patient falls outside the last known well time, outside the 8 hours, or the last known well time is vague, but the medic is kind of erring on the side of the patient and goes ahead and calls a stroke alert, and then later on we figure out that they were actually outside the window. So that's usually where most of the false activations occur. And then we actually have missed activations that we looked at. So the criteria is present, but the medics did not call a stroke alert. Fortunately, those are pretty low, and you'll see that in the upcoming slides. And I really think most of that is poor documentation, but those are some of the things that we are also looking at to help improve that process. And then we come over to the disease aspect, and a true activation under that definition is that a stroke was diagnosed and the medics called a stroke alert. So after all of the diagnostic procedures and hospital stay and all of that, that's how we match those up. A false activation is the medics called a stroke alert, but the stroke was not diagnosed. And then a missed activation, also medics did not call a stroke alert, but a stroke was diagnosed. So just to kind of give you an overview, that's how we look at the upcoming data. Okay, so for 2011, between January and June, we had a total of 486 EMS patients that fell into this, or that were called as a stroke alert. And so the way we capture this data is fairly complicated. And so we first of all, what we do is we look at the EMS data. And so STRAC provides a report that looks at the PCR data that the EMS guys have put together. And then the hospitals also submit a report, and matching those up is very time consuming. So this is where we have a lot of challenges. And so some of the 486 are not represented in the following slides because we have a lot of missing data as well. And it's just a data collection issue that we continue to work on. So I just wanted you to be aware of that whenever you see the unknowns and things like that coming up. So you guys won't have any questions on that. Okay, so we look at call time benchmarks. And if you look at the orange area at the bottom, that represents the scene times that were documented by the EMS PCRs. So out of the 486, we had 344 reported EMS scene times. So the goal for our area is for EMS scene times to be less than 20 minutes. And then if you look at the purple area, that represents the drive time, or when you put the drive time and the scene time together, that equals the dispatch to door times. So we have kind of informally agreed that that time should be 35 minutes. There's no, as far as we know, there's no national criteria that says this is what this should be. It's just kind of, we've kind of set that for our area. So you can see there's a lot of outliers there, and I'll explain some of those here in just a second. So of the scene times, We met the 20-minute mark, an overall average of 60% of the time. We would like for that to be much higher. So we are working with our EMS personnel to try to get that number down. So you'll see here, this is the first slide where we have a lot of unknowns on here. And so the unknowns represent the data collection issues that we've been having. But of the numbers that we do know about, that's where the 60% overall average comes into play. And then next we look at the dispatch to ED door. So on that other slide, the 2 slides before this is the purple area. So an overall average of 36%. Now that is much lower than the scene times because we have some issues with the collection. Well, I don't know how to explain this. With a CAD system. So the medics have a CAD system, computer-aided dispatch, where they push, on scene, en route to the hospital, at hospital, and what happens is if they don't push the at hospital button, their time just keeps going. And so that's why we have a lot of outliers on the transport times, is because they're transporting a priority 1 patient. They just want to get the patient out of the ambulance and into the hospital. So sometimes they don't push the buttons like they're supposed to. So we're trying to work with maybe getting that to be an automatic thing, to whenever they show up at the hospital, it automatically does that. But we're still working on that process. So I think a lot of that, most of the patients do get there at least closer to the 35-minute mark than what's represented here. Okay, so now we look at criteria. Now this is based on, this is the accuracy rate based on criteria. So overall we have a true activation of 87%, which means that the medics recognized that the patient was having a stroke and they actually called the stroke alert. And then we have about 10% false activations and 3% missed activations. And then we go and we look at the accuracy rate based on discharge diagnosis. So this is after the patient has completed their hospital stay and they were either diagnosed with a stroke or they were not diagnosed with a stroke. So so true activations 60%, and then false activations 37%, and then we missed at 3%. Now, let me kind of go back here. So the reason why the false activations are so much higher is that the criteria catches a lot of strokes, or it catches a lot of things that mimic strokes. So it's a pretty high sensitivity, but it's not necessarily always specific to a stroke, if that makes sense. So we're going to look at anything different or anything like that you can think of, or based on that.
Or do you want to talk a little bit about some of the diagnosis for false activation?
Oh yeah. So the reason why some of the false activations occur, so like examples would be conversion disorders, Todd's paralysis, things like that, brain cancer. So a lot of the things that mimic strokes. So they have the criteria up front, but they don't, they're not actually having a stroke. So that's the reason why I think we have a lot of false activations based on the disease process. And then, so now we come to discharge diagnosis. So the orange lines represent that the patient actually was discharged with a stroke. The purple line is they were diagnosed with a TIA. And then the others are pretty much just everything else. All of those mimickers we just talked about, they could have something, they could have anything else that just didn't fall into the stroke or the TIA. And so I think one of the good things that we see here is that the data collection overall is getting better because this all comes from hospital data. So you can see in June, we only had one unknown. So the data collection, I believe, is getting a lot better for this aspect. The other thing, too, is if you notice the others at 29%, we are sort of over-triaging this. And so I think that's a good thing. So we're actually capturing all the strokes, or a good number of them. I don't know, is there anything else we want to talk about? No? Okay. Occlusives versus hemorrhagics. So overall, it's 79 versus 21%. So it's right on with national data. Last known well times. These are for all stroke alerts. We measure, for the EMS data, we measure 0 to 3 hours, 3 to 8, and then greater than 8. So for the most part, people are calling within the 0 to 3 hour window. So they're calling, you know, when they notice their signs and symptoms. So this kind of backs up the reason why we're considering changing the 8-hour criteria. And then we also break this down, last known well times, just for the occlusive strokes, because you know we're kind of leading into the TPA window here and the TPA administration. So that's why it changed a little bit from the last known well time less than 4.5 hours or greater than 4.5 hours. So for, let's just say for June, for an example, so 28 occlusive strokes came in within the last known well time, and only one came in without or outside the last known well time. So overall average is 88% on that. The TPA administration rates for occlusive strokes, so this is where we are pretty high above the national average here. The two lines at the top are compared. So if you take, so let's look at June here. So there's 13 patients that got TPA. So you compare that to the total occlusive strokes, and that's this number here. And then the 13 versus the last known well time within the 28, or within, there was 28 of the 43 that made it within the last known well time. And so overall, we have a 52% within the last known well time and a 28% within for all total occlusive. And then we also look at what happened to the patients after they either got TPA or they did not get TPA, so the dispositions. So I want to be upfront here. The disposition does not indicate that TPA was the cause of the disposition. So just because, I'm sorry. Well, the disposition. So for an example, if the patient expired, it doesn't necessarily mean that TPA was the cause of the patient dying. It's just that's what happened. You know, that the patient got TPA, but then they ended up dying for whatever reason. And so, interestingly, it's pretty much about the same across the board. However, you know, if you got TPA, you're a little bit more likely to die than if you didn't. So that's kind of an interesting data point. But again, we need to kind of further figure out why that patient died. So that's, you know, I don't want to say not give TPA because your patient's more likely to die, but it's just kind of interesting data here. So, and then here are some of our goals. So we would like to continue to refine the data collection process. We want to provide feedback to the EMS personnel to improve stroke recognition. We would like to incorporate walk-in data as well. And the reason why we want to do that is we would like to eventually figure out what the door-to-needle times are if you call EMS versus if you walk in. And then we want to determine future goals of public education, determine if stroke alert criteria needs to be refined, and then to continue to engage all healthcare facilities and EMS agencies. And that's it.
Does the committee have any questions for us?
Oh, yes, lots. I mean, this is incredible. This is very, very impressive. One of the things that I would like to know, in Austin, it seems like a lot of patients don't call within the window. And it looked like most of the patients were calling within the window. What's different in San Antonio? How are you getting people to do that?
I don't know that, no, when you say the window, are you talking about the 8-hour window or the 3-hour window?
Either. I mean, there weren't many that were outside of the window where they could be treated. And your TPA treatment rates are the best I've seen anywhere.
I don't know that we have a good answer for why the majority of people who actually call 911 call within 3 hours. We were startled by that percentage as well, startled by that data. What we don't know and what we'd like to look at in the future is how does that compare with number of walk-in stroke patients? Truly, are the patients in San Antonio that are having stroke, are they more likely to call 911 or are they more likely to walk in? And that's something that we would like to look at. And I don't have a good answer for why we feel like we're seeing most of our 911 patients calling within the 3 hours.
So you didn't. So one thing you might do is compare the number of strokes, the hospital diagnosis of strokes at discharge, with the number of EMS, but
Yes.
still that doesn't account for people who had strokes while they were in the hospital.
Right, and that is something, we've had some challenges with data collection, as you can probably imagine, with just the sheer number of patients, and we have a stroke coordinator at every single hospital, or every single stroke center that actually looks at all of the data, and it's just incredibly, Deb is one of our stroke coordinators, she can attest to how incredibly time-consuming the data collection is, but it is, looking at total number of strokes at each stroke center compared to, how many were walk-ins, how many were EMS, but then that also doesn't collect the data of other stroke patients at other non-stroke center hospitals. So we're going to have to figure out a way to get that data as well. We've had some significant challenges with collecting the data itself. I don't know if Deb, if you can speak to a little bit more kind of what you guys go through in the hospital and some of the challenges that you've.
And specifically how much time it took, if you could tell us how much time it took and how you went about getting the disposition data or the stroke data from each hospital.
For us at Baptist, we collect everything through Get With The Guidelines. So we use that program. So through that, we're able to obtain a lot of information. As far as how long does it take, I think each patient to fill in the Get With The Guidelines, each patient is about, I would say, 60 to 90 minutes to collect the data. So it takes a long time. There's a lot of information to look up, but we include the disposition of the patient as a part of our data collection. So we're able to pull that information. We also have a full-time data person who, that's all she does strictly, is gather the information and input it into Get With The Guidelines. And we also collect some information through the MIDAS program. So we're able to do that. But it's a full-time job to do that.
What our process at STRAC is monthly, all the stroke coordinators at each hospital will collect their data and then actually send it to Justin, who then goes back and reconciles the hospital patients that were brought in as stroke alert patients. He will go back and reconcile the things that he talked about, which of these patients met stroke alert criteria and the stroke alert was called for, which ones should have been called as a stroke and weren't, which ones were called as a stroke and shouldn't have been. And he spends hours and hours each month putting that data together and then goes back and pulls out the other data, the occlusive versus hemorrhagic and all the EMS patients, what the outcome was, which ones got TPA. And so it's they meet also, in addition to our monthly stroke committee meeting, they have an additional meeting each month where they get together and compare information. And we have historically been about 2 or 3 months behind in data collection. At our November stroke meeting, we would be looking at data from August, just because it takes that long to put the data together and reconcile it with the EMS charts. Also, we've had some challenges in getting information, because obviously San Antonio EMS brings the bulk of these patients to the hospital, but we've also been working with other EMS agencies in the area that bring in stroke patients and have had some challenges in getting that patient follow-up as well. So these are things that we continue to to work on as a region.
Well, this is very great. I don't mean to hog all the questions. Do other people have questions they want to ask? Because this is really fantastic. Please, Sam.
The intercranial bleed.
Also, I'm assuming that number that got TPA was only or including the intraarterial fluid intervention?
No, I didn't. What was the first part of your question? I'm sorry, I just can't hear you from. I'm a paramedic for about 20 years, so sirens have killed my ears.
I was just wondering what the percentage of patients who received TPA, how many of those people had an intracranial bleed or major bleeding?
Well, that's one of the things that we're going to talk about looking at in the future is why the patients that got TPA, why did they develop, intracranial bleeds, or why did they die, or what was the reason for their outcome? So that's one of the things we don't capture that data right now, or at least it's not provided for the STRAC report. I'm sure the hospitals have that data, but right now we're not capturing that data. So, but that is a good thing that.
And the second question was, the numbers that got TPA, was that only the ones who got the intravenous TPA by protocol, not the ones who go for intervention and get an intraarterial TPA?
Yeah, I'm not sure. That data comes from the hospital, so I think maybe Deb might be able to address that question a little better.
I think as far as the interventional things, I would say the majority of our patients get IV TPA before they have the intervention. So a lot of those would be included in there. I don't think we specifically report just the intervention cases. And as far as the bleeds, the post-TPA, just from my own experience with our 5-hospital system, we give a lot of TPA. The national average is about 6% intracranial bleed, and ours right now is about 2 to 3%.
Great questions. Any more questions? Yes, sir.
Just a quick question on data gathering. Is this primarily on the EMS side through electronic PCR, or is this through paper? Or is there a combination, and that is a confounding factor?
It's through electronic PCRs.
Okay.
Yeah.
So all?
Um,
I'm just thinking for the 22 county area, I'm sure San Antonio, but I'm not sure on the others. That's why I was curious.
Yeah. Well, all of the data that I collect from the EMS side is through electronic PCRs. The hospitals will send back data that has the EMS agencies attached. Sometimes it actually doesn't have the EMS agency. It just is the patient was a stroke alert and they were brought in by EMS, but we don't know which EMS agency because whoever at the hospital didn't record that. But all of the data that I get on the EMS side is electronic PCR data. But the hospital would have that patient in their system. But sometimes that EMS agency is known, sometimes it's not. So that involves a lot of phone calls and emails to try to get that data, and a lot of times that data just doesn't show up.
No, I understood. That was my question, because that's a confounding issue when you get
Right.
when you have a disparity of 80% electronic, 20% paper. You can't backtrack something.
Right.
And it goes back to your point of we're trying to do education. Well, how can you educate what you don't know?
That's it.
So,
Yeah.
and I was just kind of a push towards, like, if you can go electronic versus staying on paper.
Yeah.
So.
Yeah, the far majority of our EMS services in our region are on electronic PCR now. We do have some challenges. We're continuing to work with our medics to, some of the challenges are, Justin has a difficult time in some cases determining whether a stroke alert was called or not because it's just not documented.
Right.
They didn't press the button, or, for some reason they just didn't document the last known well time. And so we're working with our medics to remember to document all of these things so we can get a little bit more accurate data. Yes.
Yes.
We've seen a significant improvement over the last year.
Great. Appreciate it.
More questions?
Comment?
Dick? Yeah, Dick.
As a follow-up, perhaps, you and I talked about this, maybe at the next meeting, I can present some individual data from our hospital system to show how we've gone from no TPA basically 3 years ago to giving a large amount of TPA, and where we've been able to accomplish door-to-needle times greater than 50% of the time for the last year for our TPA patients. And so, but also, maybe this data from the San Antonio RAC is a jumping off to things that we ought to be thinking about at the state level as far as how much TPA are we giving with all of the hospitals that we have? If so, what are the outcomes? What are the bleed rates in our state? I hate to bring up that nasty word registry that everybody's concerned about, but perhaps some kind of database, even an anonymous database or something with the data, as long as it's not too onerous. Everybody knows how much time they have and how much funding we have, but that's something perhaps the state needs to look for when I'm not on the committee anymore.
I think an additional comment, I don't know if this is the proper place really to talk about this, but I'm thinking that across the state, the stroke coordinators, we're seeing more and more of an interest, I guess, in becoming primary or support centers. And I'm thinking that it'd be really good if we could either have a listserv for the stroke coordinators or have a meeting here, when we have this meeting, but just to kind of get together to share information, because, I came from Iowa, and we had across the state of Iowa, all of the stroke coordinators met on a regular basis, and we were able to share and obtain a lot of information from one another. So I think it would be very helpful for all of us if we could do something like that.
I think a list server would be a great idea. Jane, does the DSHS support any list servers for other groups?
We have had listservs up until recently. We've been transitioning over to just Gov delivery. And we will be getting rid of those listservs because they're so difficult to maintain. We had just multiple ones. But that's the way to get at least notifications out to people.
Yeah. Well, I'll be happy. I'll look to see if there's some way we can get a list server. I mean, that seems like that would be something that we could look into do. And I'm sorry, you have a question?
I have a statement. My name is Amy Plotz. I'm the stroke coordinator at St. Joseph and Bryan. And the TTAF Acute Care Division already has a stroke coordinators listserv on the Yahoo groups. And if you just go to Yahoo groups and search for stroke coordinators, please sign up. There's lots of us already there, and it's a pretty active listserv.
Excellent. Well, that was fast. So, any other comments or thoughts?
Or you can capture
Craig Manifold, EMS Medical Director for San Antonio Fire Department. We'd like to thank the committee for allowing us to present and share this information on behalf of STRAC. But more importantly, what we'd like to do is take this opportunity to receive additional feedback, and if there are questions or concerns, we'll certainly offer up Dr. Kidd and Justin, because this is preliminary information. If there's additional things that you think we should be looking at, additional pieces of information that are of interest, we'd certainly like to continue the maturity of this process, but this is really the first public look that this information's had, and we certainly appreciate the efforts and the opportunity to have that available to you. Thanks.
Okay, well, thank you very much, and I would encourage you to publish this. I know other people have already told you to do this, but I think it's very worth publication.
Thank you very much, and if the committee would be interested, we would be happy to come back in 6 months or a year or to give an update as to improvements in our system and some of the other things that we've been able to look at. We appreciate the committee's time.
Okay, I accept. 6 months.
Thank you.
Okay. Next, we're up for general public comment, but I want to let the committee do comments first. And specifically, Homer filling in had a suggestion or some ideas.
In kind of reviewing the CE requirements for our pre-hospital people, we kind of found out that there's not any stroke-specific CEs for the EMTs and paramedics that are out there. And we've kind of talked around about this and would like to suggest and solicit some help from the state. Sorry, thank you. In highlighting some required stroke, specifically stroke CEs for pre-hospital people, just a few hours, not an additional amount of time, but take some of the open areas of, I think, the 36 hours that we have for a lot of things can fall in, maybe taking a couple or 3 hours and requiring that those be designated to stroke. Does anybody on the committee have?
Well, there already are requirements, or actually suggestions, that all first responders are taught the Cincinnati Stroke Scale, and that also that people receive education equivalent to like the stroke education within the ACLS. You know, one of the reason that was done that way was because it was to make it easy for medical directors to, you know, oh, they got ACLS, so they meet stroke education. But before, people have talked about separating something out or making a small educational component that would be a resource for medical directors in the state. And if you're interested in doing something like that, I think it would be a really great idea.
I think that if we could have 2 or 3 hours set aside on recognition and that kind of thing, and then treatment, stabilization, and a little bit of history and stroke. For us, we have to have this every 4 years, I believe, and this would require everybody that's pre-hospital certified to go through this and take this class, whether online or however, and be updated with what's going on.
I would concur.
So would you like to chair a subcommittee to see about developing a program, and then we could spread it around and see what people think?
Absolutely.
I mean, it would be, it
Yes.
acts as a resource in regards to the rules, in regards to what's required for education. We may have missed the window on that, but still to have a resource for medical directors, I think they might like that. Are there any public comments or thoughts? Is there a need for this? Are there other alternatives out there?
Well, if I can. Actually, I'm very, Homer and I talked a little bit ago, and I'm very in support of this. And really, my concern is that we go through all the topics and we don't have stroke specific. And I realized the history of it. We were trying to do case number 10 for ACLS. But with technology changing and the assessment skills and everything evolving, I think that it's time that it be brought up and be something that we look at. We can't have a stroke system in the state of Texas and not have something that ties into the CE requirements for the EMS providers. If we don't say that it's important by saying you need to have CE on it, then we can get some other neuro or some other topic that will cover it, and we'll lose them. And the ability to recognize and to deal with patients, again, has evolved. So I think if we don't do it now, or we don't at least start now, we wait a year or two from now, that pushes it back another couple of years, we're then several years behind the power curve. And I just think it's time to take it, and I'd actually advocate 1 hour per year, but I don't want to mandate that specific. But my thought is, if it's a 4-year certification cycle, why can't you do 1 hour a year equivalent? And because, again, with the changing needs, I think we need to be up on that. We're doing it with STEMI, we're doing it with all these other things we're very proactive on. But we're losing the ability to impact our patients in our communities if we don't do it and be specific with it.
Other comments? Okay, so I think what we can do at this time is we can certainly start to put together a program. And I think the state may still want to look at that. I think we need the medical director's buy-in, and I mean, I think it's a project worth, you know, starting the development in, and we can see where it goes.
I think that it's be fairly easy to address as far as making it part of the requirement of the current number of hours for CE required for the pre-hospital provider. It can just be as easy as you have to have a certain number of hours dedicated to stroke CE in that given period of time, so that they would have to seek out that education. It's very similar to what we see that people are wanting for pre-hospital care for pediatrics. They want to see some specific language, not necessarily a number of hours, but just to ensure that each provider out there has touched stroke, the education for stroke and education for pediatrics. So I don't think you are off base, and I don't think you are unusual in wanting to see something in the language of the rule.
Okay. Yes, sir.
Ferdinand Gresham, Refugio EMS. The Gordon Medical School in Miami has developed a program both for pre-hospital and hospital use. It takes about 8 hours to do the program. It can be based on live patient scenarios or videotape for the pre-hospital side. We have, down in the Corpus area, we've now got about 25 instructors to do the Advanced Stroke Life Support course. So that in itself might fulfill a whole lot of those requirements.
Yes.
Yeah, and actually we could go about, we could develop a program, but it doesn't have to be an exclusive program. What we could do is advise the state in regards to what sort of stroke education we think is appropriate, and then there might be several things that would fulfill that.
Right, and that's actually I was thinking, if we give criteria to it, we don't have to name it. Because I'm afraid of if we, like we did with Cincinnati, when we did it, it was really the best one out there. Now Miami came in a couple years ago. So I think if you say criteria, as long as it meets A, B, C, or it's a 90% match, then that should be sufficient. So I would concur that I don't think we need to start naming programs as much as we name content that needs to be in it.
Okay, so Homer, if you'll chair a subcommittee to start work on that, and then bring it back next time, and we'll see where it goes.
Okay. Would somebody else like to, I know Warren will jump in.
Denise,
Thank you.
I'm willing to help.
Good. I think anybody that wants to have an input should, and it'll be, I think, a very positive thing, and something we can get going fairly quickly.
Anybody else want to help? Everybody wants to help?
Everybody wants to help, that's great. Absolutely.
Okay. Next up, I wanted to just do a quick poll of the committee members. One of the things I think that we might do better is have liaisons to other committees. For example, the Education Committee, Medical Director Committee, Air Medical Committee. It might be nice to interact with those, and obviously one person can't do that. Is there interest that people might be willing to go to some of the other meetings and just interact and be a liaison, bringing information back and forth?
Yeah.
So if so, why don't, I'll send out an email and we can just get people to volunteer. We probably don't need 6 people at one committee, but just so we sort of spread out that work burden.
Well,
And if there were specific committees you wanted, go ahead, Warren.
I was going to say maybe even just our top 3 preferences in case 5 of us jump on EMS.
Right,
And then top 3, and we can filter it from there.
right. That's good? Okay. Next up, I have a request from DNV. Wanted to give us an update on what they're doing. Please. Have a seat.
I think I was asked, my name is Yehuda Dror, I'm the president of DMV Healthcare Inc. We are the other accreditation. Since we received our accreditation, our deeming authority from CMS about 3 years ago, we now have 250 hospitals in the U.S., 50 in the state of Texas. The largest one are the St. Luke Episcopal and Methodist. But last year, we received the approval from the state of Texas as for our primary stroke certification program to have equivalency as the other accreditation. This approval actually not just opened the primary stroke certification around the country, because I think many states in the U.S. do not have the same regimen of approval, but I think if it is good for Texas, it was good for them. So we have now about 38 hospitals that have a primary stroke certification based on the program that has been approved in Texas and incorporates some of the aspects of this. But this is more, I think that I was asked to share with you a story about the international aspect of it, because being an international organization, we are working very closely with the Chinese authorities on the Chinese health reform, which is a true healthcare reform with about 20,000 clinics that are being built over there. And in one of the discussions, they told us that they are looking for a stroke program. And in the ensuing discussion, it was quite some similarities were quite striking, because even though Texas is a little bit bigger, well, sort of, the distribution of the population is almost the same. You have about 70% of the Chinese population along the shore, similar to what you have in Texas east of 35. And we started sharing with them the same experience. And because the Chinese, as part of the reform, are looking very much to import other models, whether it is DRGs from other countries and so forth, the Texas, at least, concept of stroke is now being piloted by about 300 hospitals in rural China. So I don't know if one of these days when China has its stroke program, whether it's going to have made in Texas on it. Maybe they will have the other way around, and they will export it to the U.S. with made in China. But it is quite interesting, because this kind of activities and knowledge sharing is transcending not just states, but many, many countries. And even in the States, you have now the state of New York, the state of Washington are looking at similar programs as Texas. So I don't know if what are the activities that you have on the state level, but it is quite interesting that we hear and see that through our approach to the hospitals over there. So I just thought it would be interesting to share it with you.
I always thought we were bigger than China. It's so nice to have you here. It's unusual, obviously, to have a CEO of a big company here. Does anyone have any questions they want to ask? On like DNV certification versus Joint Commission versus, just any questions in certification? No? So I'll ask a quick question then. So Joint Commission uses a tracer methodology for their certification. You guys don't really use a tracer methodology, is that correct?
Yes.
And why is that? Why not use a tracer methodology versus using another system analysis?
I don't. Well, maybe I'm not. I would like to correct something. It's
okay.
not the tracer methodology is not an invention of one organization. I mean, a tracer is just a name of how you do audit. we do the surveys exactly in the same way. You take one element and you look at throughout the organization, whether we call it tracer or not, it's not necessarily the issue, but we definitely do it in a very, very similar way. So it's not that they do tracer and we do not. It is about the same thing, just calling it a different name.
Okay. Okay.
But just to continue, the comprehensive stroke program is something that we are now working on, and we would also present it to the state of Texas in the same way.
Yeah, and do you want to officially have your feet on the fire on when you may have comprehensive certification available?
Yes.
Okay. But you'll come back and tell us when you do?
Yeah, we will.
Okay.
Thank you.
Thank you very much. So I'd like to now open up to general comments from anyone. Does anyone have anything they want to bring up? Great.
Hi, my name is Wanda Helgeson, and I'm from Border Rack. We're out in true far west Texas. And I wanted to let you know that in the end of October, we did a Stomp Out Stroke program. And from El Paso and Las Cruces and 2 rural communities, one in New Mexico and one in Texas, we did stroke screening for over 800 individuals. And I would very much, in February perhaps, like to bring that data to you so you can see what we did, how we did it, what we learned.
Accept. That would be great.
It was a wonderful experience for everybody. We did a lot of teaching.
So come up afterwards and I'll give you an email address and we can set that up.
Okay, thanks.
Other comments? No comments? Jane, do you have anything that you want to bring up at this point? What is the status of the rulemaking and reviewing all the inputs, and what's going on with that?
The committees were to have their suggestions to the department by the end of September, and the committees did that. We have collected all of those suggestions, and we will be working probably the next 8 months, I would suspect, to come up with a draft. All of those suggestions, we go through them and we look at them to see, is it something that we can incorporate into the rule? If it's a licensing type rule, licensing is minimum standards. If it's designation is a little bit different. We look to see if we have the authority statutorily to do some of the things that are in the suggestions. And then the staff writes those, the rule language. Whatever rule is written has to go through our general counsel office, and it has to be reviewed and approved by general counsel before it can go forward. Once we have what we consider a good draft, then we will bring it back to GETAC and the committees. What I'm hoping to do is have a joint committee meeting at some point in time. I mentioned next November, and one of the committee chairs almost fell out, and they said, please don't do it in November. So we don't have a good timeline yet. We won't until we start to get into actually doing some of the rule language revision and going through all the suggestions. We got a lot. Some sections of the rule we had no suggestions for, and we'll just do some cleanup on those. Other sections of the rule, for instance, the designation program for hospitals for trauma, we asked the trauma committee to do a lot of work on that, and so we've got a lot to do on those sections. So you won't see it again for at least 8 months, maybe more. Okay.
Great, thanks. Okay, anyone else have any other thoughts? And Jane, our next meeting, do you know the date of the next meeting?
I do. It's going to be earlier in February. I believe it's the 9th and 10th. Let me see here. 8th, is it? 8th through the 10th.
8th through the 10th.
Week after ISC.
Say again?
Week after ISC.
Right. It is impossible. The International Stroke Conference is in New Orleans, I think 8th, 9th, and 10th?
No, it's the 31st, it's the 30th through the
30th?
through the 1st or 2nd.
Okay. Okay. Well, if there's nothing else, we stand adjourned. Nothing? Great. Thank you, guys.